Welcome everyone. We're going to get started today. My name is Cara DeCorby and I'm the Managing Director and Knowledge Broker at Health Evidence, and I'm filling in for Maureen Dobbins today as she was called away to assist with the workshop. So I want to welcome everyone and thank you for joining us today. I know there are many competing priorities on your schedule, and we're going to go over a little bit of housekeeping and then we're going to get right into the content. So for our housekeeping announcements, we wanted to ask that you use the question and answer or the Q&A to post comments or questions during the webinar. If you have a question, we'll make sure that it gets addressed in the Q&A. We will likely take up questions around the review content at the end of the webinar, but we will make sure that those questions get answered, and I'll moderate that at the end of the discussion. Please send your questions to all, as opposed to privately to host. If they go privately to host, it's hard for the panelists to make sure that they get on the list to attend to them. And if you're having any connection issues with the webinar or with the audio, we recommend that you call the WebEx helpline, and just around the connection itself, we recommend you use a wired internet connection versus wireless, and that seems to help prevent connection challenges now that we've done, I think it's about 20 of these. So learn from our experience, and if you have it available, please use a wired internet connection. I wanted to introduce you to the Health Evidence team so that you can see us. I know you can't see us right now, but there's on the left-hand side Maureen Dobbins, our Scientific Director. And then on the top row, myself, Heather Husson, Jennifer Yost, and on the bottom row, Lori Greco, Robin Trainer, who's online with us today, and Lindsay McRae, a research assistant who's not able to be here today. First of all, I wanted to introduce you to what is health evidence. I'm not sure whether all of you are familiar with health evidence, but I won't spend a lot of time on this, just so you have some idea who we are and why we're there. Health-evidence.ca is a repository of all of the published systematic review literature around the effectiveness of public health interventions. So it's trying to answer questions about what works, and it's all review-level evidence. So hopefully those reviews have already summarized all of the primary studies in an area so that you don't have to do that. So we're trying to save you time. So in addition to pulling together all of the relevant public health reviews in one place, we also provide a quality assessment of those so that you don't have to do that critical appraisal work yourself. And I think today, after hearing about the review process from Julie and Paula, you're going to have an appreciation of how much work that can save you. So we've assessed all of the reviews, and you can run searches for free online at our website. And when you get the results, they are automatically sorted according to quality. So the high quality reviews will show up first. And hopefully that helps increase your use of research evidence and your ability to do that. So just to recap why use health evidence, we're hoping to save you time. We know no one has enough time in public health. It's all relevant and current review evidence. There's a transparent process, so you can read all about our process and see for yourself the tools that we're using to sort reviews and include reviews in healthevidence.ca. Keyword them, and then quality assess them. We also have additional tools and supports for EIDM available, and we hope that our website is easy to use. We're always incorporating reviewer and user feedback, and we'd love to hear from you. If you use the website and send to the Contact Us link, that goes to both Robin and I, and we'll make sure that we address your concern. And if it's a bigger picture idea, we'd love to put that on our wish list of things to do for our site in the future. So today, what we're going to be talking about is a review, and our ability to bring this to you in a webinar is a result of a CIHR-funded project through the Knowledge Translation Supplement Grant. This project is actually, the purpose of this project is to help us get the word out about the content of relevant and well-done reviews in public health. So today we actually are talking about a review that was done through another CIHR-funded project called the Partnerships for Health Systems Improvement grant, and that was a project that was started in 2009, and we've been working with consultants in Toronto Public Health. Two of those consultants have completed a very well-done, thorough review, and we wanted to use this as one way to share the results of that in case that was useful to people in any other health units within Ontario, across Canada, or anywhere, actually. So just before we get started, I'll introduce the two presenters that we have here today and who I've been fortunate enough to work with since January on this review. Julie Charlebois has a Bachelor of Applied Science in Nutrition and Food from Ryerson and a Master's of Health Science from the University of Toronto. And Julie, for the past 16 years, has worked at Toronto Public Health and is currently a health promotion consultant within the Chronic Disease and Injury Prevention Directorate. For the past 5 years, she's been the coordinator of the Toronto Healthy Communities Partnership, funded by the Ministry of Health and Long-Term Care, and more recently has added child injury prevention work to her portfolio. So the other presenter today is Paula Waddell, and Paula has a Bachelor of Nursing degree from the University of Toronto. Paula joined public health 22 years ago and has worked in many capacities, delivering frontline service and managing community partnerships, always with a focus on chronic disease prevention. For the past 10 years, Paula has been a health promotion consultant with Toronto Public Health, supporting staff and management with strategic support in the chronic disease and injury prevention portfolio. So I'm going to be handing things over to Julie and Paula to present the results of their review, but also to give you an overview of the process that we used, walking you through the evidence-informed decision-making process in a really practical and applied way, so what that meant in this case in undertaking this review. So I think you'll get an appreciation for the work, and you can feel free to ask questions about either the process or the content, and we'll keep track of those questions and make sure that they get addressed at the end. So I'm going to hand things over to Julie right now, and I'll let Julie take over from here.
Thank you, Kara. Okay, so we're just going to switch spots here. Advance this one. Okay. Thank you all again for being here. As Kara mentioned, we're going to go through a process that we recently went through over the summer to do this research. And so today, what we're going to cover is, Kara did talk a little bit about the project, which is the FISI project, Partnerships for Health System Improvement Project. And I'm going to talk about the goal around that. I'll cover some steps of the evidence-informed decision-making process and the process that we went through. Then we're going to be talking about the review of the evidence and recommendations and next steps within Toronto Public Health. Okay, so the Partnerships for Health System Improvement, as mentioned by Kara, was awarded through a CIHR grant, and Toronto Public Health has been involved in this project, as well as a few other health units across Ontario. And the main goal of the project is to explore how to best enhance capacity for and facilitate context conducive to the EIDM process in public health. And Kara's been working with a few groups within Toronto Public Health, and one being our group looking at this research. So this is just a quick slide to show you the definition through the National Collaborating Centre for Methods and Tools, the definition of evidence-informed decision-making. So it's the process of distilling and disseminating the best available evidence from research, practice, and experience, and using that evidence to inform and improve public health policy and practice. So the other piece of the evidence-informed decision-making process that I'm just going to cover now is the 7 steps that we went through in developing our report and doing the research around obesity prevention interventions in schools. The first step being defining the research questions. So most of you are probably familiar with PICO, which is I'll speak to a little later. The second step being search, so searching for your evidence. The third, appraise, so that's appraising your evidence using critical appraisal tools, and we're going to speak to some of these great tools that Health Evidence have online. And then synthesizing, so compiling a report based on the evidence that you found. It might include data extraction for systematic reviews, studies, and guidelines, and then interpreting or forming recommendations for practice based on the literature found. And then the next step being adapt, so kind of adapting that information and those recommendations to the local context. In this step, we'll be talking about assessing that information around applicability and transferability, and then implementing and evaluating once you get to that. That step. This is just showing you the model of evidence-informed decision-making in public health, and it involves integrating the best available research evidence into the decision-making process. So there are additional factors that create the environments in which the research evidence is interpreted and applied. So it's important to keep all these other pieces involved or in mind when looking at the evidence. We'll just quickly go through those just to show you how they all work together. Okay, so Paula and I are going to go through our evidence-informed decision-making process in developing our report focused on school-based obesity prevention interventions. Initially, we actually started our processes separately, but then we eventually merged our research. So we're going to speak to the two separate research questions we started with, and then how we kind of merged as we went along. So as mentioned, the first step of our process was to clearly define the question or problem in a searchable and answerable format. What we did was we developed a PICO question, so looking at the population, intervention, comparison, and outcome. Within our project, research questions were established or identified by the management team based on evidence needs within our Chronic Disease Injury Prevention Directorate. So some priorities were identified, and then we further fleshed out the research questions that we were going to be looking at. This is the first question that was identified. What interventions or strategies are most effective in low-income communities or neighborhoods to address risk factors related to obesity? This was a question that was something I was going to be working on, and then I'd also like to recognize a master's student we had working here over the summer with me from Queen's University, Yasso Garanathan. So the second research question focused on physical activity, but also on children and in schools and their participation in physical activity. So what school-based programs are effective in increasing physical activity participation in higher needs elementary schools? So similar to question one, but specific to physical activity, children and schools. So the next, our next step after identifying our clear and defined questions was for us to actually start searching for evidence. So we used the levels and sources of public health evidence pyramid to find the best research evidence with the least amount of time and effort. So we started at the top of the pyramid and worked our way down until we generated enough evidence for the research questions. And we concentrated our findings within the first four levels: system, summaries, synopsis, and of synthesis and synthesis. We were able to do this because the first four levels of evidence generated a sufficient quantity of synthesized evidence, so we didn't need to search single studies. Sorry, the slide, yeah, the slide is a little odd. Sorry, the font changed on the first research question. But these are basically just examples of some of the search terms that we have for question one and question two. And we tried to keep the search terms broad so that we could cover most of the relevant documents. And as we were doing our search, we did use a tracking tool, and this is something that is available on healthevidence.ca, and was a great tool to use because all the databases are listed there and helps us move down the pyramid. This is a snapshot of the tool. And so under each database, we documented when the search was undertaken, the terms that were used, the number of results outputted from each search, and then the tool provided a very directive approach to accessing the literature, which was very helpful. These are some of the databases that we searched, and the time frame. We searched from about 2007 to May 2012. We also, besides searching databases, we did also have discussions with colleagues, and I tried to identify any other things that were happening out there. Now, at this point of doing our research, a lot of things were happening over the summer. The Active Healthy Kids report card came out. There was a lot of political attention on the levels of lack of levels of physical activity in children. Also, a lot of interest in the child obesity epidemic. Again, that's about the report card. The Institute of Medicine released their report, Accelerating Progress in Obesity Prevention, the Weight of the Nation, and schools were identified as one of 5 critical areas or environments for change. So their focus was that schools should be a national focal point for obesity prevention. And then we also had Deb Matthews create the panel, the Healthy Kids panel, to tackle childhood obesity, and their report will be due out at the end of the year. They were asking for submissions from organizations and so on, and actually the report that we're speaking of today, we did submit to that panel. So basically, at this point, with all this happening, political and media attention, there were some internal discussions around piloting an obesity prevention initiative within Toronto Public Health, somewhat modeled after the Diabetes Project. So through discussions with our manager and director, we actually decided to focus the research question, number 1, a little bit more to look at school-based prevention interventions targeting elementary school children. So this created a further filter for us when we were going through our documents. And I mean, we know that the school environment is profoundly is a profound influence on students' attitudes, preferences, and behaviors. We already have a lot of existing collaborations with the schools, and in terms of outreach, we would not only be involving students, but also parents and families. So internally within Toronto Public Health, this became our focus. So we needed to kind of look at how we were going to apply that now within our research. This is so one way to visualize the process that we went through is to use this flow chart. I know it's kind of probably hard to see, but this was really helpful. This is actually a flow chart for the first research question that we had. And you can see the enormous amount of information that comes out through doing a search. About a total of 393 reviews and guidelines were screened based on titles and abstracts. And then we went through our primary inclusion criteria, which is on the right-hand side, which basically identifies that the research needed to reflect our PICO question. We were focused on prevention and not treatment. The research had to be within 5 years and also in English. So that resulted in our 64 articles as potentially relevant for full document assessment. So then we further removed about 11 additional guidelines and protocols, and we also removed some other guidelines that were a little too general for the previously stated PICO question. And then protocols were also removed. So as I mentioned, due to Toronto Public Health's interest in exploring more intensive interventions for children within the school setting, we actually created a secondary relevance criteria to further filter the search process. And that's a great opportunity if things do come up and you are looking at other criteria, you have the opportunity to insert that criteria. So we added that, and the criteria was age around, so ages 6 to 12 or senior kindergarten to grade 8. School setting, so it could be before, during, and after. And then we also had a criteria around low-income, minority, high-priority, or high-risk populations. Prior to assessing the full documents, based on that secondary relevance, the reviewers actually included the obesity guideline developed by the National Institute for Health and Clinical Excellence. Some of you might be familiar with that one that was released in 2006. Now this guideline was included even though it wasn't within our timeline criteria because of its high quality, relevance to the research question, and its repeated inclusion in other reviews. So there are opportunities to also identify other research out there to include, provided you do have a rationale for including it. So bottom line, in the end, we ended up with a total of 9 articles, 8 systematic reviews and 1 guideline, to move on to the next step around the quality assessment piece. This is a flow chart looking at the second research question, and that was the other question related to physical activity. I'm not going to walk through all of it, but in the end, there was a total of 6 documents, 5 systematic reviews, and 1 guideline that was selected for quality assessment. Then once we actually looked at the 2 flowcharts and all the documents, we were able to identify the final systematic reviews and guidelines that we were going to actually be looking at. So this is step 3, which is appraising the research that we had. This is actually a snapshot of the tool from Health Evidence. We want to make sure we assess the quality of study methods in order to determine if the findings are trustworthy and meaningful and relevant to our situation. We were very lucky. As Kara mentioned earlier, there are a lot of pre-appraised systematic reviews on Health Evidence. This is the snapshot of the 10-point quality assessment tool. And of our 9 systematic reviews, all of them had been assessed at Health Evidence, and they were all rated as being strong or moderate. And we did not include any of them that were weak. Now, in terms of the guidelines, needed to be appraised using a different tool. This is the Agree-To tool. It just, on the slide here, we just included all the different domains, and there's a number of questions. I believe there were about 23 questions to go through. A lot longer process, and in particular because we were actually assessing the NICE guidelines, which is over 2,000 page document. We would just pull out the pieces that were relevant to our research, and we appraised based on that. And then we did appraise the CDC report as well, which is around school recommendations. All the references are included in the report at the end and within the report as well. So these were the systematic reviews we included. The 2 guidelines aren't listed there, but these are all the systematic reviews and how they rated in terms of their quality assessment. So high, moderate, 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 high, high, moderate, high, and high. Since our research on both of our research questions, basically, we're focused on school-based interventions for children ages 6 to 12. At this point of the EIDM process, we decided to merge the 2 searches into 1 document before we moved on to step 4 of the process. In order for us to do that, we did, as I mentioned already, we did identify the duplicates, and we removed a number of them. So we ended up with 5 high quality and 4 moderate quality systematic reviews. So this basically was our new PICO question that we identified. We were now going to be looking at what school-based programs are effective in low-income communities and neighborhoods to address risk factors related to obesity in children ages 6 to 12. And now I'm going to pass the mic over to Paula, because she's going to then move on to the next step of the EIDM process, step 4, which is synthesize. If I can get out of the chair. Thanks, Julie.
Okay, so the next step in the EIDM process is step 4, which is synthesize. And it focuses on deciphering the actionable messages from the research evidence that you have reviewed. In order for us to make final recommendations, reviews and guidelines were organized into a matrix table, and relevant data was extracted for the synthesis. Extracted data was further categorized into review characteristics or review outcomes, and these really percolated up from the nature of the information that was presented in each of the systematic reviews. So on this slide, you will see a list of the categories that were used, both characteristics and outcomes. Since the guidelines presented a set of recommendations, as a result, the recommendations were extracted along with any relevant results. So the results that we're presenting to you today were based on the 9 included systematic reviews. The results from the systematic reviews were used along with the findings and recommendations from the NICE guideline. And as Julie mentioned, that's the National Institute for Health and Clinical Excellence guideline. This guideline included results from its literature search. So it was used as supportive findings when developing the recommendations for the final report. The other guideline that we had looked at was the Center for Disease Control and Prevention guideline, but it did not properly report the findings from their literature search. It made recommendations without detailing the findings, so it was not used when recommendations were developed. We did, however, look to that CDC guideline when we looked at supporting arguments for the discussion portion of the report. So when you look at the way that we have analyzed our results, you'll see that there are 4 categories. The first is physical health status measures, and that refers to literature that has spoken to anthropometric measures, i.e. BMI, waist circumference, cholesterol, and/or blood pressure. Physical activity measures included the change in physical activity rate, step counts, physical activity levels, physical activity behaviors, sedentary behaviors, and/or reduced television viewing hours. Dietary measures included the change in food and nutrition intake and/or dietary behaviors. And psychosocial measures included change in knowledge, attitude, preference, measurement of self-esteem, well-being, and quality of life. So within those categories, we were able to collect evidence on this more detailed set of variables. So, just scanning through them, dietary-based or physical activity interventions, psychosocial, psychoeducational variables, duration, family, community involvement, intervention delivery based on setting and provider, tailored programs, education-only interventions, multi-component interventions, environment or policy-based interventions, peer leaders, and incentives. So when we looked at the information that we had available to us, there was evidence to make a recommendation on each of these variables. Appendix A in the report, for those of you that have seen it, if you want to review Appendix A after the presentation, it outlines the rationale for the decisions made on each of these recommendations. So without further ado, we will present the recommendations. So, as we said, the recommendations were divided up by theme. So this is the first theme, but just to give you a little overview, the themes are setting an audience, diet-based interventions, physical activity-based interventions, multi-risk approach, multi-component approach, and other intervention components. So I'm going to walk through each of those groupings with you. The systematic reviews used to develop these recommendations reported their findings according to outcome measure. So that was how we characterized them. Because of this, specific outcome measures are identified in some of the following recommendations, making it more complex but also more helpful. So I'm going to highlight some of this because even as Julie and I have gone back to the document time and again, we would take a look and really try to make sure that we've got the true gist of each recommendation because it varies based on the outcome measure that's being addressed. So in this first set of recommendations for setting an audience, you'll see that obesity prevention interventions with strong support for the school setting. There was strong support for targeting children, elementary school-aged children aged 6 to 12. There was support for mixed gender groups when delivering group-style interventions. There was support for interventions in schools and lower socioeconomic neighborhoods to increase physical activity levels and improve dietary intake. And there was support for targeting all children versus interventions that target high-risk populations. So that's just to take a little look at the last two. The socioeconomic neighborhoods, this was, of course, as Julie had mentioned, was on the radar of Toronto Public Health already. This was one of our screening criteria as we were trying to get a sense of what interventions worked for disadvantaged groups. So that was all the information, all the evidence that we looked at. That was a criteria. It spoke in some way to working with disadvantaged groups. So the fact that we came out with a recommendation that we should be doing this to increase physical activity and levels and dietary intake really supported the direction that Toronto Public Health was wanting to take at this point in time. And then the last one about targeting all children versus interventions that target high-risk populations. Again, in our screening, we screened out any literature that focused only on children that had been pre-diagnosed as being overweight or obese. The included literature represented a population approach within their studies. So we were able to say, and there was evidence to formulate a recommendation that really it is the population approach targeting all children with an intervention that will help all children within that target group. The next set of recommendations were dietary-based interventions. So this is where I was saying you need to really pay attention to the outcome that is spoken to within the literature on which a recommendation is made. So we differentiated between the literature that really demonstrated the results on anthropometric measures versus literature that demonstrated results on dietary intake and or dietary behaviors, because they differed. So in terms of dietary-based interventions, we should not implement dietary-based interventions alone to improve anthropometric measures. And just to recap, that was when we spoke about anthropometric measures, that was BMI, waist circumference, cholesterol, and or blood pressure. We should implement dietary-based interventions to improve dietary intake and or behavior. So this is versus anthropometric measures alone. So there is value in dietary-based interventions, but if you're going to be measuring BMI as your outcome, then do not focus solely on dietary-based interventions. TPH should implement environmental and or policy-based interventions, such as breakfast and or fruit and vegetable distribution programs to improve dietary intake. So once again, it's the dietary intake that goes up through that type of strategy. We should not implement that type of strategy focusing on BMI as an outcome because it will not show demonstrable change. For physical activity-based interventions, we should implement physical activity-based interventions that decrease sedentary behaviors to improve anthropometric. Okay, I have trouble with this word. Julie's laughing at me. Anthropometric measures. I may say it wrong again, but that's what I mean. Anthropometric measures. This is also consistent with literature that's been available to public health units through the RNAO, which is something that Toronto Public Health is partnering on right now through the Best Practice Spotlight organization. This was one of their recommendations around decreasing sedentary behavior. So this is not a new idea, but it reinforces the importance of it. We should also implement physical activity-based interventions that focus on extended physical education classes and activity breaks to improve anthropometric measures. And those activity breaks are activities that happen outside of the physical education class. We should not implement physical activity-based interventions involving fitness enhancement for anthropometric measures. And so this is fitness as opposed to physical activity. And lastly, we should implement physical activity interventions to increase physical activity measures, including physical activity and or sedentary level. And once again, the use of activity breaks as an illustration is one intervention that has shown to be successful. We should not implement physical activity curriculum alone to increase physical activity levels. And you'll hear more about that when we get to the point on multi-component strategies, but this statement is saying curriculum is not enough. and TPH should implement environmental or policy-based interventions to increase physical activity levels. And so the environmental or policy-based work that public health units are involved with is strongly supported. So the multi-risk approach. So there's two different aspects of this, multi-risk, and then there's multi-component. So of course, multi-risk is speaking to the fact that physical activity and dietary-based interventions are both identified as being supported by the evidence as factors in obesity prevention. When you take a look at the evidence around the two, the evidence is strongest, or there's the highest level of support, is when these two are done in combination. So the risk factor messaging or strategies should be done in combination for physical activity and dietary based. And that is to affect anthropometric measures as well as physical activity and dietary behaviors. So it's across the board. So, moving away from the multi-risk and now looking at multi-component, which is more about our strategies. So we should incorporate a multi-component approach to obesity and prevention, including behavioral, environmental, and educational components, including health education, enhanced PE, and promotion of healthy food options. So the education component should also be multi-risk. Okay, so physical activity and nutrition together. So we should not implement either physical activity or dietary-based education in isolation due to its limited impact as an obesity prevention intervention. So aside from the specifics around physical activity and nutrition, there were other intervention pieces that came through fairly strongly in the evidence as well. The first one was around psychosocial and psychoeducational components in the programming. And there was evidence that this should be and was included in most of the evidence that we reviewed. And it was defined in different ways because there was great variability across the studies that were included in the systematic reviews that we looked at, nevertheless very strong support. That the duration, that the implementation should last at least 3 months. So this was not new knowledge to us, but it's an ongoing challenge, just speaking from a Toronto Public Health perspective, that we need to be paying attention to as we review these recommendations and look at how long, the duration of the interventions that we are delivering. We should also incorporate a family component into all obesity prevention interventions, and tied to that, we should aim for a high level of parental involvement in obesity prevention interventions. So the literature really showed that the higher the level of parental involvement, the stronger the evidence was for a positive outcome within the 6 to 12 age group. Peer leaders. That we should use peer leaders in interventions focusing on obesity prevention. But given the age group that we're studying, which was 6 to 12-year-olds, application of this recommendation would have to be age appropriate. There's obviously different roles that student leaders play within that quite variable age range, so that is something that would have to be looked at a little in more depth. Incentives and interventions were helpful, and the specific one that was teased out from the literature was focusing on increasing fruit and vegetable consumption, was shown to be very positive. The partnership with school staff and intervention specialists, very strong support for this from the evidence, and this is not new thinking, I guess, for anybody who works in public health, but the greatest bang for our buck is when we partner with representatives from the organizations that we work in, and specifically this was school staff in school settings. And overall, just a final statement, when planning and implementing and evaluating obesity prevention interventions, the harm or unintended effects must be considered. It is of a concern that only a few studies in the selected systematic reviews used in this report examined such effects. This concern was further emphasized by the CDC where the guideline recommends creating a school environment encourages a healthy body image, shape, and size among all students and staff members. It further recommends providing health, mental health, and social services to students in order to address healthy eating and physical activity. Programs should implement safeguards and regularly evaluate intended outcomes and unintended consequences. So that ended the development of our recommendations from the literature. So once you have a set of recommendations, the next step is to take a look at the applicability and transferability of those recommendations to your local context. So here's a snapshot of the tool for assessing applicability and transferability of evidence by the National Collaborating Center on Methods and Tools. And this one in particular is used when starting a program. There's also another tool that is used when ending a program. So this is the stage we are at right now in Toronto. A stakeholder group has been determined that can best assess the recommendations for applicability and transferability in Toronto. So we've been through our first go at looking at the recommendations as a group, and it has generated excellent thought and I believe directions to set the stage for the next steps. And those next steps for us here in Toronto are to finalize our decisions or our recommendations that come out of the applicability and transferability tool, to examine the current Toronto Public Health programs for gaps and opportunities based on the recommendations that we've obtained from the literature, and to use all of that information to develop an obesity prevention pilot project here within the City of Toronto. In an ongoing way, Julie and I have been very fortunate to be part of this process with Health Evidence, and so we are going to maintain a role of, not formal knowledge brokering like Kara, but to a lesser degree, I guess, within Toronto Public Health. So there's opportunity to share the learnings of the process with other consultants within Toronto Public Health, our other directorates, and our child staff that work specifically with this age group, our chronic disease prevention child staff, and our Healthy Communities school youth team staff, as they both are working in the school setting with 6 to 12-year-olds. And also, as Kara mentioned at the beginning, there are other groups within Toronto Public Health who are working on different FISI projects with Health Evidence. So, we're building a core group of staff within Toronto Public Health who are more familiar with these tools. And then once this work has been, I'm going to go back one step. So once the pilot project, of course, is decided upon, the last 2 steps of the 7-step process are to implement and evaluate, and that completes the evidence-informed decision-making process. So I will turn it back over to Kara now, who's going to close.
So I want to give everyone a chance to ask questions and give us a chance to answer those questions as best we can. And there has been a question that was just sent to the host, so not everyone can see that. But I'll read out the question because I think it's one we can address. So someone has asked around the intervention component to use incentives focusing on increasing vegetable and fruit consumption at school. Are there any references that talk about potential harm for the students who are not able to bring vegetables and fruit for whatever reason? So was there any discussion of the impact that might have if they're not able to do so? I think that's something that research is sometimes criticized for not addressing, and potential harms is something we try to look for, but it's not consistently there in all of the review level evidence that we looked at. And I'm going to hand the mic over to our reviewers so that they can also comment on that.
Yeah, Kara, that is something that Paula had mentioned in terms of TPH, or that in terms of our recommendations, that TPH should address harm or unintended effects when planning, implementing, and evaluating obesity prevention interventions. And in particular, some of the things that are looked at are around weight surveillance and that kind of stuff. But that's a good question in terms of that kind of side of things. But unfortunately, a lot of the reviews that we did look at didn't focus on that. One systematic review did, but like I said, it was focused more in terms of weight surveillance and so on. I think Paula maybe has something to add here.
Just speaking specifically to that one, the recommendation that I guess I understand is there was some question about was using incentives and interventions focusing on increasing fruit and vegetable consumption, e.g. rewards provided when fruit and vegetable servings are eaten at school. It is a good question because we don't want to, if children are required to bring them from home, that would potentially create harm. Whereas there are other interventions where the onus is not on the child, where maybe it's exploratory within the school setting. So not to go too deeply into it, but once again, putting an overlay of doing no harm over top of any of these recommendations, there is a way to meet these recommendations without, hopefully that would be part of the screening and criteria on how we would choose an intervention.
So there's been another question. Were there any references that advised against using anthropometric measures and focus mainly on change in behaviors such as improved eating and improved physical activity?
We're both smiling. Certainly, we've discussed this at length, and the focus on anthropometric measures, unfortunately, is very prevalent within the literature as an outcome. And you can see through our 2 PICO questions, we brought in literature that focus on both type of outcomes. So it is, depending on who you're speaking to and how you are having to frame a question, then you may be asked to speak to either type of measure. Certainly there is a lot around BMI in the literature. That's not our, to editorialize, it's not necessarily our choice, but that's the situation as it exists.
Oh, sorry, there's more to add here.
Sorry, and if you do access the report that we did write, in the discussion on page 31, that was actually something that we had identified right away, that we actually should address the use of BMI as an outcome measure. And you'll see a little bit more information related to that in the report.
So we've had another question on, were there any interventions that stood out that you will be looking to pilot, and if so, what?
Yeah, well, actually right now we're at the stage where we've pulled this group together, and as Paula mentioned, we're looking at the applicability, transferability. What we're doing now is we're kind of looking at some of those prevalent programs that did see some positive outcomes, and we're actually looking more closely at them. We've been pulling them off, actually, the best practice, the portal, the PIAC portal. So some of the programs that have come up are GEMS and CATCH and Pathways and potentially Apples, but they don't have much evaluation stuff right now. But we don't believe we can actually just kind of pull out one of these models and actually do it. There's obviously going to be pieces of the interventions that will be applicable. So I don't think we're going to be able to just kind of, it would be nice if we could actually just identify an intervention in one of these reports and say, hey, this is what we're going to pull and we're actually going to do. But that's where the work, the next piece of the work comes, is actually looking at a few interventions and pieces of those. And then we also have to look at internally what we're already doing and what we can use and what gaps there are within what we're already doing. So it's going to be different for every every health unit, every group that's looking to develop these interventions, to kind of look at your local context, again, what resources you already have, and then to start applying. This kind of gives us that beginning point where we can at least say the research is saying this. So, and we even have to kind of look, like I said, look even closely at some of these programs to see the real kind of pieces and be able to drill down now.
We have another question from Manitoba around what evidence did you find, or how do you intend to address language or cultural barriers for newcomer populations? Was there anything in that area?
Well, there definitely was information related to adapting and actually addressing cultural barriers. So it definitely was identified as something that, and again, in the report, it didn't end up in a specific recommendation because there was that focus around, well, no, it didn't end up in a specific recommendation, but in the discussion, there's actually a piece around making some adaptations depending on cultural and different cultural backgrounds and so on.
Okay. So you'll be able to access that in the discussion section of the report, and Robin has posted in the chat the link to be able to download the full report online, so you can actually access a copy of the report itself. Another question is around intake. So when reviewing the evidence specifically around intake, did any studies talk about portion control?
No, I would say no.
No, and the answer was no, that there wasn't anything about portion control in the literature at this time around this question. Not that there shouldn't be. It didn't come through right now with this question. There may be other questions, and certainly around if that was an outcome of interest, then a suggestion might be to start with that as a main part of the search in your PICO to make sure that that outcome is being covered. So there's another question. Can you provide more detail on the pilot that Toronto Public Health will be working on in the area? And I'm not sure if there is more detail at this point, but I'll hand things over to Julie to comment on that.
There's actually, we've put in an internal business case because there was potentially some city funding that might be available, and because our medical officer of health is very interested in this this area and issue, we actually submitted that. So we won't actually know until the spring if there is some funding specific to the program, but we know we do have commitment from our director to possibly redirect some of our current services to be able to do this pilot. So we are going to kind of be moving forward, and assessing our resources is going to be obviously a piece of that. And we are looking at potentially looking at 2 neighborhoods within Toronto because we do have some data related to obesity in specific areas of Toronto. Yeah.
And Kelly, I hope that answers your question as well around a pilot. There were a couple of questions about just wanting more detail on what was happening with that. And there was also a question around timeline, so I think Julie has addressed that. There was another question, was there any info about the risks of using rewards for eating behavior? So some theories do not advocate rewarding children for what they eat or don't eat. Was there anything around that? We're just thinking about that question, and I'm going to hand the mic over to Paula.
I don't think that we specifically saw anything about that, but back to the comment about the adverse or unintended effects, it was noticeably absent in a lot of the literature. And so whereas we have the higher level guideline from CDC that says we really should be addressing this, sadly, it wasn't addressed consistently, almost non-existently across the board. So no, we didn't come across anything really that addressed that issue.
So we're just have a poll underway right now, and you can answer that when you have a chance. We just are wondering whether you found the information presented today helpful, and we're also wondering whether this information was new to you. This is a new review that has gone on over a period of months, and I think you can appreciate now the work that went into it. But we're wondering whether it's helpful and new to you just for our own curiosity, so please contribute to the poll if you can, and those will be our last polling questions. I just want to see if there have been any more questions. Yeah, we have another question. Do any studies look at cost effectiveness of the interventions? For example, if the school has to supply the fruits and veggies for students to try and receive an award, there will be a cost to this. And I know that was a big part of our A&T discussion, our applicability and transferability discussion, so I'll also let our reviewers comment on that.
It wasn't something that we were actually looking at, but I know, again, like Kara said, in our applicability transferability discussion, it certainly has come up, and we actually received some information from one of our managers who had attended another conference in Nova Scotia that actually had a listing of a number of different initiatives and interventions, and some of the ones I mentioned earlier were on that list. So that is definitely, again, because it wasn't the focus of this review, it's something that we're going to be looking at in our next stages for sure.
So I'm just checking to see whether there are any other questions coming in. I'm not seeing any right now, but since there have been a lot, I'm just going to give people another few minutes to ask questions. Robin has posted the link to the report and where you can download it in the chat, and maybe we'll post that one again, Robin, if you can repost the link to the report in the chat. We're also going to make available the copy of the presentation, so the PowerPoint slides, for you if you'd like to see them again, or if you know someone who wasn't able to attend and would like to see them, and that will have the audio to the presentation. So you'll be able to hear the audio along with the questions and answers. And I see that I've missed a question. Sorry, Doug, I'm going to scroll back up. There's a question around the CDC and NICE guidelines that I seem to have missed. I see it now. So thank you for the compliment, and Julie and Paula, excellent presentation, especially the detailed steps taken in the review. There's a comment that a cursory reading of the CDC, NICE, and other reviews using author conclusions in their abstract seems to suggest that physical activity interventions alone will not have much effect on weight. Consequently, it would seem advisable to place more emphasis on diet-based interventions while not dropping the idea of combined physical activity and nutrition interventions. And a question just asking for the reviewers to comment on that idea.
Well, definitely we did see a big focus on combined, so the actual multi-risk approach and multi-component approach in terms of interventions. I mean, we do definitely, when we go back to our dietary-based interventions, that first recommendation was that we should not implement dietary-based interventions alone to improve anthropometric measures. So that's basically saying, you know, caution just doing dietary-based in order to address BMI. But when you look at the multi-component, you can improve actually all measures. That's what these systematic reviews were telling us. And then in terms of the physical activity, that first recommendation we had on slide 25, in terms of anthropometric measures, decreasing sedentary behaviors was related to being able to improve anthropometric measures. So just going back to those recommendations, Paula, do you have anything to add?
And it's not just the sedentary behaviors, but the physical activity interventions as well seem to produce improved anthropometric measures. So we were kind of describing this when we looked at the overall literature, is if you're looking at anthropometric measures as your outcome, and you're looking at dietary-based, you don't want to do that alone. There is some evidence for physical activity alone, but where you're going to have the strongest evidence is where you've got dietary and physical activity in combination in terms of anthropometric measures.
So we have 3 more questions that have come in, and a comment actually that at PLO region, they're currently working on a rapid review around effectiveness and cost effectiveness of physical activity interventions for school-age children. So for anyone who's asked about cost effectiveness, and that wasn't something that was a focus of the current review, you'll want to check back in with Peel later. And April, I hope we can connect about that to find out a timeline for that, so that if people are asking us for it, we can certainly refer them on to you. So a next question, have you decided which outcomes you'll be measuring in your pilot? I'm not sure if things are at that stage, no. But no, the answer was we're just not there yet, I think. Is that right? No. Okay, yeah, Paula and Julie are shaking their heads that we're not there yet, but feel free to stay in touch. So a few more questions. Although you may not have been specifically looking for this, did you notice how often academic achievement and student success had a relationship to health behaviors, and how often was that noted in the literature? Was it noted in the literature?
I would say noted in terms of discussion, but not something they were looking at in terms of the actual outcomes.
So not consistently noted as an outcome, or no analysis. Was there evidence that promoting diversity in body shapes and improving self-esteem had any impact on anthropometric measures, activity, or nutrition?
Well, if you look at the recommendations under other intervention components, we have a recommendation around TPH should include psychosocial, psychoeducational components in physical activity and dietary-based interventions. So those measures were increasing knowledge, attitudes, preferences, but also self-esteem, well-being, or quality of life. So that certainly was looked at in a number of systematic reviews, and based on what we saw, it came out as a clear recommendation.
Thanks, Julie. So we had a comment from someone that it would be nice to know how many participants were on the line from the beginning. So I'm not sure we really had a firm beginning because people are pulled away to a lot of other things. But on the line today, we had about 150 people, just for those of you who are interested. So just to let you know that there are other participants. I know we're not hearing from everybody, so it might seem like you're alone out there, but there were 150 other people in the virtual room. So we've had another question. Was there any mention of before and after school programming for physical activity or active commuting, like walking to and from school?
Oh, yes. Yeah, definitely active transportation was something that was looked at, yeah.
Okay. So you can download a copy of the report to see more specifically what was discussed around that. Are there any unintended negative effects with single gender programs, for example, girls only?
Well, we know that some of the systematic reviews did look at some single gender programs, such as GEMS, for example, African American girls. But again, like we said, there's only one systematic review out of the 9 that actually looked at any unintended effects. So it was not a focus of those reviews, even if they were a single gender intervention.
Yes, I'm going to hand this over to Paula, who has another comment.
Just to add that there were quite a few single gender study articles included that did not show unintended effects, but they did not also show evidence of a positive effect. So you just can't say anything about those. I mean, the recommendation was pulled out where there was a positive effect, which was in mixed gender groups.
Okay. And around unintended effects, definitely something for the literature to look at, hopefully more consistently in the future. Another question, will public health have a role in strategies for the collection of anthropometric measures? So a bigger, more strategic question. Can you give your thoughts on that?
Actually, there is a Toronto Public Health Student Survey being developed, and we actually have already piloted within the Toronto Catholic School Board. And the plan was to start data collection in both school boards, Toronto District School Board and Toronto Catholic School Board, in January. We've actually just in the last month received information that that is actually going to be delayed, and part of the reason being the labor disruption. So we are looking at doing this weight surveillance. This is for secondary schools, though, not 6 to 12-year-olds. Sorry, it's grades 7 to 12, and so we're looking at actually implementing that in the September 2013-2014 school year. So we shall see when that comes.
Okay. So we had, there was another comment that Peel Health has completed the student health survey, and a report will be available soon. So there are different iterations of that, I guess. We had a comment that asking about whether interventions or programs which Toronto Public Health currently offers, which may be inconsistent with the evidence, is there a way to look at those and decide whether or not there's any scaling back or such to do? And I'll hand the mic over to Paula.
That is part of our intended process. You know, public health really wants to work in an evidence-informed way. So part of our process will be to review the current slate of interventions that we have to determine if things need to be changed or modified, if they need to continue in a different format, or you know, how they need to come together to make a more comprehensive approach for schools. And just, you know, to say there are a lot that line up with already, just, you know, knowing our programming, a lot of it does already line up because it was evidence informed from the beginning, but it is time to revisit it and see if it's still fresh and current and how the pieces work together to create the best impact for schools.
Thanks, Paula. And we've had another question. How can one integrate the activity breaks into the school day, assuming we want children to gain 30 minutes of physical activity per day?
Well, the way that it was framed in the literature was before, during, or after. That doesn't preclude advocacy within the school day, within class time, you know, DPA type activities, but it also includes the time frames surrounding class curricular time.
And another question about how many, about viewing the presenters. Someone has asked if it's possible to view the presenters, and we end up kind of doing the webinars where we don't always have the ability to view the presenters. So we're also, I think we're all getting gradually more and more comfortable with webinars. So, you know, maybe when we've got a good comfort level with the chat and with the, you know, speaking to an audience we can't see, we'll be more likely to want to be viewed ourselves. So it's something that we'll consider, and thanks for your comment. We've had another question. When studies found positive results, was there any carryover of those positive results after the formal intervention ended? So do the benefits last beyond the intervention?
Yeah, the sustainability of kind of the interventions, or the sustainability, I guess, of the positive health behaviors varied amongst the studies and systematic reviews. In terms of follow-up, that actually varied quite a bit. There could have been follow-up from a few months, or let's say no follow-up, to a few months to up to a few years. So I wouldn't say it was consistent, so it's very difficult to answer that question, but certainly that's something that I know within our interventions and within our future programming related to this, we will definitely be looking at.
Thanks, everyone. That was the last question that was asked, and thank you all for your great engagement today during the discussion. I know that I asked you to save your questions to the end, so we definitely appreciate that you obviously kept track of them and did that. I hope that we've answered them all, but we've provided contact information if you need to get it to reach Health Evidence, which would be either myself or Robin, so Kara or Robin, and also Julie and Paula's contact information is there. And Robin has also posted the link to the report, and you'll also later this week, I guess there's not too much later this week to get, is there? It might be at the beginning of next week, but you'll be able to view the slides and hear the audio. And so if you know someone who might be interested in this material, we'd be happy to have you pass that link on so that they can view it as well. So that's all of the time that we need to take today. We know you have a lot of work to get to, so we'll say farewell for now, and feel free to contact us again. Thanks very much.